Hello guys, welcome back. Hope I'm audible and visible. If so, just give me a thumbs up. I hope I am. Okay, so we're just going to continue from wherever we left in the morning session. I hope you were a part of the morning session. And we're going to continue the same thing today. We'll see a few more MCQs. We'll go in depth and analyze the concept and maybe learn something surrounding that. Fine. Okay. As usual, a few things to update for you guys. Please be free to attend the free test given for you. The Feb month schedule is out in the special class and everything. Please use all the tests. There are PYQs. Please use them. There'll be study with me series with Dr. Preeti as well as Dr. Cheshta. Use them if you like it. Fine. And there's an unlock 30, which is 20, which is there on today and tomorrow, and maybe tomorrow on day after. Maybe use it for your use. Fine. Okay. So let's go ahead. And if you're a plus subscriber, you can enroll to any of the batches which is going to help you. There's an ultra revision batch that might help you. If you're not a plus subscriber, you can subscribe if you like it with Pathogenesis. There's a 1 month subscription as well. You can use that as well. Fine. Right. So let's go ahead. And start the today's discussion. Again, as usual, I'm going to display an MCQ. I want you to give an answer to that. I'll just zoom out a little bit. Hope you're able to see the entire MCQ. Please go through the MCQ and comment on the answers, and then we'll have a quick discussion about the same. Fine. I want you to comment on the answer. Who is live, please do comment on the answer. Even if it is wrong, it's completely fine. 30 seconds. If this is very small, I shall zoom this bit for some time. I'll tell you the important things here. This is important to come to a diagnosis. I'll zoom out to back to the question. Comment on your answer. Anyone? Okay, so bit of a fine. I'll read through the question. In the process, if you're able to find out the answer, do comment on the answer. Fine. It's a 12-year-old girl who presents to the pediatrician with an cola-colored urine. So there's a patient with a history of an hematuria. In the patient words, it's a cola-colored urine. To go with that, you have a RBC count of 10 to 18, great action, per high power field, right? And not only that, see, when you have an hematuria, it can come anywhere from your urethra. It could be an UTI, it could be a bladder calculi, it could be many causes, right? It could be a trauma even. But I have one more classical history of cast being formed. You do have an RBC cast. So cast will be formed in the kidney, in the tubules. So only thing which can be involved in the cast, only if the problem is in the glomerulus, right? So this history is such of an glomerular hematuria. Because of the RBC cast, I'm going to think of an glomerular hematuria. The reason being, so it's in glomerular hematuria, my first differential diagnosis, it's a case of nephritic syndrome. See, when I take nephritic syndrome, segmental sclerosis and hyalinosis is FSGS. FSGS will present as nephritic or nephrotic. I think that's a simple question. FSGS will present as nephritic or nephrotic. They present classically as a nephrotic syndrome, so that cannot be the answer here, right? Wire loop of capillaries is suggestive of an SLE. Hypercellular and an enlarged glomeruli is suggestive of PSGN or a PIGN. Mesangial proliferation is suggestive of an IgN nephropathy, right? So all these are possible of cause of nephritic syndrome. Both A, B and D, all of them are possible cause of nephritic syndrome, right? So now let's go back to the history. With the first line, I've got only this many informations. I already with the first line itself, I can rule out this option, fine? So according to her mother, she had a sore throat of 3 weeks ago, right? So I have one more classical history. So I'm having a lesion secondary to sore throat. SLE is not going to be secondary to sore throat, so I can strike off this as well, right? If it is SLE, you'll have a very classical different manifestation of your photosensitivity or hemolytic anemia of that sort, right? So coming back to other two options, I have a mesangial proliferation and PSGN. Your PSGN and IgA nephropathy. Both PSGN as well as IgA nephropathy can happen secondary to your sore throat. It's possible for it to happen secondary to a sore throat, right? Or an URI. But the only clue here for me is it is 3 weeks back. The lag time is very long. If it is an IgA nephropathy, keep this in mind. It will help you for differential diagnosis. You have an history of an URI. right? So post URA, let's say 2 to 3 weeks, you have a lag time. Post 2 to 3 weeks, you're going to have hematuria. Okay, this is the first scenario. The same URA, you're going to have the second day, which means there is no lag time at all. The second day, I'm having hematuria, right? See, both are nephritic syndrome. The only difference here is the lag time, because both can happen secondary to your URA, right? The first possibility, it's PSGN, post-streptococcal or a post-infectious. Second possibility is your IgA nephropathy, fine? So if you have no lag time between the onset of the URA or an UTA, whatever it is, and you have an hematuria from the glomerulus, I'm going to think of an IgA nephropathy. Just because I have a 3 weeks lag time here, it cannot be an IgA nephropathy. I can rule this out as well. The first two lines are enough for me to come to a diagnosis. So what else is there? We'll just go through it quickly and we'll know what's there. There is she denies fever, any change in the bowel habits, nothing, fine, everything is fine. BP is fine, okay, pulse rate is okay, temperature is also okay, respiratory is also okay, right? The patient develops a pitting edema, it's fine, because when you have a nephritic or a nephrotic syndrome, I'm going to have slight proteinuria, I'll have definitely problems with the renal dysfunction. That might have caused this. And a normal oropharynx. Oropharynx will definitely be normal because the 3 weeks back had a sore throat. Now definitely oropharynx is going to be normal, right? So urinalysis shows the following finding given here. And what is my diagnosis here? And come to the urinalysis. When I say urine is dark brown in color, an RBC of 18 to 20 per high power field. HPF stands for high power field. So to interpret urinalysis, first and the foremost thing is I need to know what is normal. When will you call it hematuria on a microscopy? Because you have to know that, otherwise you will not be able to interpret future questions based on urinalysis. The minimum amount of RBC should be at least 3 to 5 per high power field. Only when you have more than 3 RBCs per high power field, I can call it hematuria. If you see 1 RBC per high power field, it is considered normal. So don't call that nephritic syndrome or don't call that hematuria. Same goes for WBC as well. 1 or 2 is completely normal. Without history, without symptoms, these are completely normal findings. Ignore that, right? Protein, definitely even a minimal amount of protein, 1+ is also significant. Actually, microalbuminuria, which is like 30 milligram, that's also significant for me when it's protein. Because for every normal person, protein should never come in the urine. If it comes, something abnormal. What is the clue when you think of a microalbuminuria? You have one classical disease which will have microalbuminuria. What disease is that? That's kind of one of the earliest presentation of the disease as well. Microalbuminuria, you'll think of diabetes, right? That's one of the earliest presentations of diabetic nephropathy. Keep that in mind. Glucose is absent, fine. Crystals none. Ketone absent. Nitrate absent. Nitrates is just of an UTI. If nitrates are positive, I'm going to think of some WBCs is there in the urine, most probably in UTA. Could be your pyelonephritis as well. Nitrates generally says there's an UTA, that's all. There's an WBC involving there, that's all. And 24-hour urine protein excretion is 0.6. Though it's not normal, it's slightly elevated, fine. So with the base of my urinalysis also, I know it's a nephritic syndrome only, fine. We'll just go a quick look about the difference between a nephritic and a nephrotic syndrome. I'll just erase this part. See, because there are few times when you have a tabular column of the disorders, we generally tend to memorize everything, right? These are nephritic, these are nephrotic. We don't go in depth and analyze about the disease per se in order to understand why it is nephritic and why it is nephrotic, right? That's very, very important for us. Only when we understand that, we will not make mistakes in future, fine? So to know abnormality, the first and the foremost thing for us is to know normal. Let's take a normal glomerulus. I'm sure you know the structure of normal glomerulus, so I'm just going slightly faster, fine? So there is a basement membrane. It's a very thick basement membrane, glomerular basement membrane, made of obviously collagen, right? And the inner surface of a basement membrane is your endothelium. It's a capillary, right? Every capillary will have an endothelium. I have an endothelium. On the surface of it, I have a basement membrane. The outer surface of it is what you have your podocytes or your food process. See, this entire thing is called as a filtration barrier. If you remember your physiology, I call this a filtration barrier. In other words, this 3 layers is the one which is going to be the barrier between a blood and the urine for understanding lumen and for understanding Bowman's. Okay, so this is going to filter everything, right? So I'll take two filtrations here because I have to differentiate between nephritic and a nephrotic syndrome. So I need to differentiate how my normal membrane filters protein and how my normal membrane filters RBC. RBC normally should not go into the Bowman space. It should not go. It will not be filtered from its circulation at all. So it will not happen, right? Because for an RBC to go outside, I need a physical space. I need a gap. So normally RBC don't go outside, but proteins do get filtered. It will be reabsorbed by my tubules. That's totally different, but they'll get filtered, right? So if you remember your physiology, just tell me, I need your help in this. How do you think proteins get filtered, or what are the factors which determine filtration of a protein from your blood to your Bowman space? There are two main factors which help in the filtration of protein normally. I'm sure you must have read them. One is charge, the shallow proteins. Other one is your pore size, right? The charge and the pore size, perfect, right? So one is going to be pore size, the other one is going to be charge. So charge is there on the shallow proteins which will be present on the filtration barrier. The pore size is the one which is going to be determined by your food process. The food process is like this, right? So if the food process expands like this, pore size becomes bigger. The food process becomes smaller, the pore size becomes smaller, that's all. So these food process actually move like this. It keeps moving like this, so it easily filters the size of the protein what it wants. I'll ignore charge for now. I'll take pore size, right? So if the food process is the one which is going to determine the pore size, let's say that I'm having a disease which is going to destroy the food process. Am I right in saying that even the biggest protein can come outside? Yes. I'm going to have two disease process. In one disease process, what I'm going to say is I'm having the basement membrane, I'm having the endothelium, but my food process is gone, kind of damaged. A damaged food process. Will all the protein come outside? Even the bigger molecular weight protein, because food process is lost, right? So that's my first thing. When I have any disease which is going to damage the food process or your podocytes, it will filter large amount of protein into your Bowman space. So in other words, can I call it will cause nephrotic syndrome? Yes, it has to cause nephrotic syndrome because even the largest protein, albumin, is going to come outside. So I'm going to call it a nephrotic syndrome, right? So this I want you to know. If you know the pathogenesis, if it destroys my food process, it will cause nephrotic syndrome. FSGS will destroy it. Membranous will destroy it. Your minimal change disease will destroy it. Any disease which affects the food process will cause nephrotic syndrome. That's the bottom line. If you know what disease affects food process, you can extrapolate which disease can cause nephrotic syndrome. We'll come to the second disease process. The second disease process, I'm going to, the other way, is nephritic syndrome, right? See, if I'm going to talk about a disease of a nephritic syndrome, right? So tell me which or what will be the classical presentation of a nephritic syndrome. Is it proteinuria or hematuria? What is more important for any person for a nephritic syndrome, protein or blood or RBCs? It is going to be RBCs, right? So my main thing for me here is RBC or hematuria should come outside and proteinuria is a little bit less, right? So I need an RBC from a lumen to go outside in a Bowman's. In a normal scenario, right, leave kidney, when do you think an RBC will exit a capillary in a normal scenario? Will it exit normally? Can an RBC diffuse, or only when the capillary rupture it will go outside? Only when there's a damage, right? Otherwise RBC will never come outside. Only when there's a damage in the capillary it goes outside, right? So I have three layers here: food process, endothelium, basement membrane. Which of these three things do you think is very, very strong? Endothelium, food process, or basement membrane? Undoubtedly the strongest person is going to be basement membrane, right? So what's going to happen here is, I'll draw whatever is going to be there. So if I'm going to have a basement membrane which is completely broken, this is a normal basement membrane, I have a gap there, right? I have a gap, it's completely broken, or I have a basement membrane which is injured, which is damaged, right? Just for understanding, whatever completely thickly shaded is a normal part. If you have a complete rupture of a basement membrane, it can definitely cause a nephritic syndrome, or a damage to the basement membrane, it can definitely cause a nephritic syndrome, right? So my main difference is this: it has to either rupture or undergo damage. It will automatically come outside. Let's take Goodpasture syndrome. What do you think is the pathogenesis? Every case of Goodpasture syndrome will have one particular thing. What is that? Goodpasture syndrome will have antibodies against collagen 4, right? It's nothing but antibodies against your basement membrane. So in a Goodpasture syndrome, we'll have nephritic or nephrotic syndrome. Because I'm having antibodies against basement membrane, which means it will destroy the basement membrane, it will have nephritic syndrome, right? So anything which damages my basement membrane, that's the clue, will result in the damage, will result the RBC to come outside, it will cause your nephritic syndrome, right? So that's a simple thing. Your crescentic glomerulonephritis, there will be a rupture of basement membrane, nephritic syndrome. Your PSGN, in PSGN, I'm going to have inflammation. When inflammation happens, leave kidney inflammation, normal inflammation. Am I right in saying that there will be diapedesis in any inflammation? Will it happen? If diapedesis happens, my WBC can go outside. In that condition, can an RBC go outside? It will. So PSGN, damage to basement membrane will be there. It will not be ruptured, damage, nephritic syndrome. IgA nephropathy, inflammation, damage will be there, nephritic syndrome, right? So whatever damages basement membrane will cause nephritic, whatever damages food process will cause nephrotic syndrome, right? So I can easily differentiate what will cause what. Okay, so this is the basic difference between nephritic and nephrotic. That's the first part which I want you to learn. Second part, I wanted to discuss something about your SLE. Because SLE is a very classical finding, and wire loop lesion is a very classical finding for SLE. We'll just have a quick look about it. Fine, but then we'll go to the next question. I'll just erase this for the time being, right? So what type of hypersensitivity happens in SLE? Just to kickstart the discussion, we'll go with easier questions. What type of hypersensitivity happens in SLE? In SLE, you have type 3 hypersensitivity, right? So what happens in SLE is, I'm going to have type 3 hypersensitivity, which is circulating immune complex. Fine. The immune complex is there in circulation. That's my main problem in SLE. So in SLE, the immune complex is not the main problem. When the immune complex gets deposited on your vessel wall, right? When it gets deposited in the vessel wall, it's an antigen antibody, that's the immune complex, getting deposited in the vessel wall, that will trigger inflammation, that causes vasculitis. Same way it causes glomerulonephritis as well, right? So you must have drawn glomerulus when you are in your first year like this. You must have put a cup and you must have drawn capillaries like this. You must have drawn capillaries like this, like a hairpin shaped capillary, right? I'll take one capillary alone outside and let's see how that capillary will cause your nephrotic syndrome, right? Let's assume this is your hairpin shaped capillary. Fine. So the blood goes via this, the blood goes here and the blood comes outside here, right? That's how the blood flows in a hairpin shaped capillary. So tell me logically, in this hairpin shaped structure, where do you think the blood flow will be sluggish? In this part 1 or in this part 2? Where do you think blood flow will become sluggish? Obviously the sluggish blood flow will happen in the part 2, right? That's what is going to cause you sluggish blood flow. If there is a sluggish blood flow in the part 2 because of a hairpin shaped curve, so can I say the deposition of the immune complex will also happen in the part 2? Yes. So what happens here is the deposit happens here. That will cause you vasculitis, right? It will cause the antigen antibody reaction. It will cause vasculitis. Let's give it few more years. In few more years, the vessel changes. What happens here is the same hairpin shaped vessel. The only change is this deposit would have permanently damaged the structure. So my vessel would have gotten some amount of injury, wound healing and fibrosis. So now that's an obstruction for me. So am I right in saying that when that obstruction happens, 1 is this, 2 is this here. Now can the second part again have a turbulence? Because of this pre-existing damage, the second one can have a turbulence, right? The part 2. So when that turbulence happens, will it again deposit? It will. So what happens here is, I will use a new color, okay? I'll use a new color where it gets deposited, fine? Okay, it's going to get deposited like this. So again, what's going to happen here is the same immune complex, and I'm going to have deposit from here, because of the turbulence, it goes all the way high, it circulates like this, right? So now logically, again, I'm going to use your same logic. Tell me the answer. Am I right in saying that for this deposit to happen, first from normal to this, then damage, then here, will it take more time or will it happen immediately? It should take time, right? First deposit happens, changes, the turbulence changes, then more deposit and forms a structure like this. So this thing is a wire loop lesion. That's a wire loop. It looks like a wire loop. It looks like a microbiology wire loop, right? So it takes lots of time. So now tell me, if I give you a history of wire loop lesion, it will be seen in class 1 lupus or class 4 lupus. This wire loop lesion will definitely be a classical finding in class 4. It can be sometimes seen in class 3 also. In class 1 lupus, I will not see it because I need time for it to form, right? So wire loop lesion is nothing but due to the pathogenesis. It's a deposit, subendothelial deposit, and it is most commonly seen in class 4. I'll show you a classical wire loop. We learned the pathogenesis, right? So I might talk many things which might not be there in your classical Robbins. So I might either bluff or I'm talking from a post-graduation book. But I need proof for that. If this is true, I need to look at the wire loop. It should look the same, right? There's a classical example of a wire loop, fine? If you look at this wire loop, I'll use this color. This is a glomerular capillary loop. This is an entire loop for me. I am drawing the dotted lines, which is not having the deposit. The edge alone has a deposit. Here again, dotted lines for not having the deposit and the straight line for having a deposit, right? So it classically looks like a wire loop. Again, dotted line, no deposit, straight line, full deposit. Classical like a wire loop. Yes, dental Q, a transition from a normal to the first thing, right? The first thing will take few minutes, right? few years, which means that my class 2 condition will have deposition only here, which will not look like a wire loop. Again, from that to the class 4, which is called as a wire loop, will take more time, right? That will be there in class 4. Just to make it even more better, am I right in saying that I'm going to the previous image? Am I right in saying that now the disturbance happens here also? Will it happen? Yes. So will the amount of immune complex extend completely? Will it extend completely? It has to, right? If I give more time after class 4, it will extend completely, right? If it extends completely, I'll have a blood vessel like this with a deposit all over, right? Yes. So can I call this looking like a membrane? Can I call this membranous? It looks like a membranous glomerulonephritis, right? If it completes the entire circle, it looks like a membranous glomerulonephritis. If you remember or if you have read classes of lupus nephritis, class 5 is actually membranous. Class 5 of lupus nephritis is membranous glomerulonephritis. Let's even more do it better. If the membranous glomerulonephritis, I leave it for few more years, will it become more thicker and thicker and thicker and occlude the lumen? Is that possible? Becomes more thicker, lumen becomes smaller. Possible? So if I leave class 5, the class 6 of lupus nephrosis is called as an advanced sclerosis, which means the entire lumen is gone. Ischemia, infarction, necrosis, wound healing, fibrosis. Right? Class 6 is the last stage. Fine. So the lupus nephritis is just due to type 3 hypersensitivity happening in the glomerulus. I'm going to extrapolate with the normal anatomy of the glomerulus. Fine. So that's what happens in lupus. 3, 4 might have wire loop, 4 has more wire loop, 5 will be membranous, 6 will be sclerosed. Fine. Okay. Any doubts in wire loop? I hope I was clear. Fine. So we saw one question regarding this. Okay. Again, one more question. This might be a new concept for some of you. Some of you must have definitely known this. Comment on the answer and then let's go and have a look at it. Anyone to kickstart the discussion? Anyone to answer? It's fine if you're wrong. There are a few classical informations here. Okay, Tanish has started with A. Anyone wants to add to it? Choriocarcinoma, Staphylococcus, great. Anyone else? A D again, okay, great. Okay, A again, fine. See, we'll go through this. We'll come back to the answer for sure. We'll go to the question first. The products of conception from a 20-week-old gestation is analyzed, right? It's a product of conception. Do you think choriocarcinoma will present as a product of conception? Will I call it as a product of conception? When I say choriocarcinoma, it's a neoplasm, right? It's not a pregnancy-related condition, right? So it is not a choriocarcinoma just from my history. Because choriocarcinoma is a very, very aggressive tumor. It will form like a nutrient mass or swelling more than the age of gestation and will have lots of hemorrhage with metastasis, right? That itself is not suggestive of choriocarcinoma, but still we'll go through it. We'll keep it in mind, fine? Analyze with P57 immunohistochemistry. We need to know P57 IHC, then I can easily interpret it, right? Expression of the P57 IHC is detected in the villus trophoblast, which means in this question, in the products of conception, P57 is positive. That's what is being given. Expression is detected. Subsequent genotype shows biparental diploidy. Fine. Biparental diploidy. See, both information are required for me. Now tell me the answer. An incomplete mole is diploid or not? We'll use very, very basic things. Incomplete mole, diploid or not? Incomplete mole is triploidy, right? 69 chromosomes, fine. So it cannot be an incomplete mole. It has to be 69 chromosomes for an incomplete mole, right? It's not a diploid. Okay, now we'll take a complete mole. If you remember a complete hydatidiform mole, is it biparental? Is it biparental or single parent? You must have read about the pathogenesis of a complete mole. It's generally an empty ovum with 2 sperms, right? It's not biparental, right? It's single parent. So when I say biparental, which means the male as well as the female counterpart is there. So it cannot be a complete mole also. So by history, it cannot be a choriocarcinoma. It cannot be an incomplete mole. It cannot be a complete mole. So the only answer possible is your non-molar pregnancy, even if you don't know anything about P57. Don't get stuck if you have some new information given in the question. See what can I do with the available things, right? I do have available history. I have 5 lines. I can definitely come to a conclusion. So without even knowing about P57, I can come to the conclusion it is a non-molar pregnancy. It's an abortion, that's all. Abortion need not be always molar pregnancy, right? So but still we'll read about molar pregnancies. We'll read about P57, how to interpret them. We'll also look at choriocarcinomas, fine? Okay. So this is a simple image from Robbins. I am sure you must have seen this image, right? It's a very superb image from Robbins. So when I say complete mole, it's a sperm with an empty ovum. Either a duplication happens or dispermy, 2 sperm fuses. It's an abnormal pregnancy. That's why 2 sperm fusion is also possible. For a complete mole to happen, it should have 46 chromosomes only, but it should be uniparental. And the uniparent here, it should always be the male counterpart. It should be the sperm. The ovum will always be empty in a complete mole. Keep that in mind. But in a partial molar pregnancy, I'm going to have ovum, but dispermy. So both are going to be there. There are going to be 2 sperms involved, plus I'm going to have ovum. Every sperm is 23 chromosomes, so it obviously has to be a triploid. Partial mole is always 69 chromosomes. It's triploid. Right? Both of them cannot survive. Neither a complete mole nor a partial mole. Both of them will definitely undergo abortion only. The only thing here is you can have fetal parts. Right? You must have definitely read this. The simple reason why I'm having fetal part is a zygote cannot become a fetus if only one parent is there. I'll go here. This is not a zygote. It's a sperm again, right? Both are sperms. It's a sperm again. Only when the female component and the male component comes, they can form a zygote. They can form something of the fetal part. Here I do have both of them. But unfortunately, one sperm is in excess. So again, it cannot form a viable pregnancy, right? So it undergoes abortion, fine? So this is here. Again, I'm going to ask your help so that we can understand P53 easily. A very, very simple question. Tell me, in which of these 2, complete or a partial mole, maternal component is present? Maternal, mom's component. Which of these 2, mom's component is still present? Partial or complete? It should be present in your partial mole, right? Because only partial mole has ovum. In complete mole, there is no ovum, right? In a partial mole, perfect. Your maternal component is present, right? Now let's look at P53. There are two names, P53 or KIP2. Keep that in mind. It both are same, one and the same. P57 or KIP2, both are one and the same, right? So normal P57 is coming from the maternal genetic component. Don't read the second line. Maybe I'll push it down. A normal P57 comes from the maternal component only. So if it comes from the maternal component, do you think complete mole will have P57 staining? Yes or no? The normal P57 comes from a maternal component or a maternal copy. So in a complete mole where there is no maternal copy, P57 will be absent, right? If my P57 staining is absent, it is definitely a complete molar pregnancy. That's all. Now I'll take partial molar pregnancy. In a partial mole, will P57 be positive? In a partial molar pregnancy, will the P57 be positive? Obviously, right? P57 will be positive in a partial molar pregnancy because I do have the maternal or the ovum component. Fine. Definitely it's there, it will be positive, right? So it helps me to differentiate a complete molar and a partial molar pregnancy. That's the simple ideology of P57. P57 is actually an imprinted gene. So in a complete identiform mole, right, you'll have a negative P57, right? That's why you have to remember about it. If my P57 is negative, it is not a complete molar pregnancy. It could be partial molar or any other abortus. Any other cause of abortion will cause that, fine? So we know about this. Now again, going back to the question. The question says that expression of P57 is detected, which means it is positive. Again, it cannot be complete mole. It has to be in incomplete mole or a non-molar pregnancy. So my answer here is non-molar pregnancy because of biparental diploidy. That also is required for me. If it's biparental, cannot be your complete mole. Diploidy cannot be a partial mole. Fine. So we know how to know this. Fine. So we'll just have a quick look about your gestational trophoblastic disease. Before that, this image. I had put an Instagram video as well describing a molar pregnancy which came in the hospital. That they are it is a products of conception, not a molar pregnancy. Products of conception are very, very common, and you have to know this. Then you have an entirely empty space surrounded by these cells. I'll highlight a few cells. Tell me what they are. I'll zoom in a little bit. I have to zoom in for this. This cell particularly, this is a single cell. This is single nucleated or multinucleated. That alone will be enough for us. Single nucleus or a multiple nucleus. The cell which I have highlighted, it definitely has multiple nuclei, right? So when I have a multiple nuclei, perfect Sakshi, it's in syncytiotropoblast. So it's a giant cell, right? So this is an syncytiotropoblast. So when I see syncytiotropoblast, it's a giant cell. It's a physiological giant cell. There are very few physiological giant cells. One is a syncytiotropoblast, and osteoclast in the bone is also a physiological giant cell, right? So rest everything is single nucleated cell. These are my cytotrophoblast. Okay, I do have cytotrophoblast and I do have syncytiotropoblast as well. Again here, syncytiotropoblast. Every multinucleated cell is in syncytiotropoblast, right? So I have a lumen-like space surrounded by cyto and syncytiotropoblast. This is an villi, your trophoblastic villi, right? So we call it trophoblastic villi because it is lined by trophoblast. That's all, right? So if the villi is very big, that's hydatid-form, hydatid-like. If you remember hydatid, it looks like an big, you call it tender coconut appearance, right? A big vesicle, like that it looks, right? It's hydatid-like molar pregnancy, so we call it an hydatid-form mole, fine? Okay. So this is a brief description of your gestational trophoblastic diseases. I'm not sure if this classification is important for you. If it is important for you from a gynecological point of view, do remember them. But I divide a gestational trophoblastic disease molar pregnancy, which includes complete and partial. We can have placental site nodule, which will just cause an continuous bleeding per vaginum even after the delivery. It's just a placental site lesion or an exaggerated placental site. These both, the two things are highlighted in green, they are not neoplastic. They are just proliferations, that's all, right? But GTN stands for gestational trophoblastic neoplasm. The neoplasm includes benign as well as malignant. Invasive mole is also a neoplasm. The only difference between invasive mole and normal molar pregnancy is in your gynecology, again, you must have read about placenta percreta increta. You must have read about it. What is the unique thing about placenta percreta or an increta? There's only one unique thing. It can invade the layers of myometrium. Same way, an invasive mole invades the layers of myometrium. That's all, right? It's a molar pregnancy. It's not just going to cause an abortion. It invades inside. So which means my treatment should be based on the patient. The ideal one is you have to remove the uterus, because the molar pregnancy is there in the layers of myometrium. I cannot do anything, right? So CC stands for choriocarcinoma. That's one of the most aggressive thing. One history for choriocarcinoma which should always be there is there should have been a history of abortion or a normal pregnancy or a molar pregnancy. This should be there. Without this, choriocarcinoma cannot happen, right? The previous history of any of this should be there. Without the history of any of this, having a choriocarcinoma is like extremely rare, right? PSTD stands for placental site trophoblastic tumor, and this is epithelioid trophoblastic tumor, fine? So I should have any one of this to form choriocarcinoma, okay? Choriocarcinoma is a very aggressive neoplasm. Again, when I have very aggressive neoplasm, there are two things which are common for that. Can I say it can undergo metastasis very frequently? Any aggressive neoplasm for that matter, can they metastasize? They can, right? What's the most common organ of metastasis for choriocarcinoma? That's also an MCQ. These are extremely vascular tumor. So hematogenous metastases are very common. Where does it go into? It can go into lungs, right? Lungs is one of the most important organ where choriocarcinoma can undergo metastasis. Again, it's a very aggressive tumor. It grows very fast. So if it can grow very fast, can I give chemotherapy to destroy it? Any fastly growing neoplasm, can we give chemotherapy to destroy it? You can, because it divides fast. Chemotherapy destroys dividing tumor. Choriocarcinoma do respond to chemotherapy. If you remember from your OBG, I hope the same chemotherapy regimen still holds true. This is the one which I read during my final year FBS, IMACO regimen. If they have changed it, please read the new ones, fine? So your IMACO regimen is one of the chemotherapy regimens for choriocarcinoma, and they do respond well to chemotherapy, right? So this is the gross appearance of a choriocarcinoma, fine? Okay, with methotrexate, great. This is a gross appearance of a choriocarcinoma. Only one thing I want to add to the gross appearance of choriocarcinoma. One, there will be a mass. It will be hemorrhagic. It will be extremely hemorrhagic mass, because cytotrophoblast or syncytial trophoblast or placenta for that matter is a vascular thing. So this is also a vascular lesion. Second thing, this might help you to write to avoid a wrong diagnosis or a wrong answer in an MCQ. When I have blood when it's fresh, it will be in red color, right? When I store the blood in the specimen, the same uterus, if I store in the pathology department for the say next 5 years, do you think it will stay red in color or it will change color? It will change color. It changes to brownish color, right? So on a stored specimen, your choriocarcinoma can have a brown-black color. So keep this in mind. In a brown-black color in a specimen of a uterus, you have to think still about a choriocarcinoma. Put a disclaimer, not melanoma. Please keep this in mind. It need not be melanoma. Okay? It need not be a melanoma. It's still a choriocarcinoma, because melanoma in uterus is an extremely rare condition. Fine. Brown black color uterus, still a choriocarcinoma should be the first possibility. Swati, previous pregnancy or a previous normal delivery or a previous abortion, something should be there. See, because choriocarcinoma arises from trophoblastic tumor lesions, right? A trophoblast will not be there in a woman normally. Only when placenta is formed, trophoblast comes. That trophoblast becomes cancerous, right? So there should have been a history of some implantation. Without implantation, choriocarcinoma is an extremely rare condition, right? Okay. So microscopy of it, it's a very high grade tumor. It will have very pleomorphic cells. It will have lots of pleomorphism. Again, I'm sure you can identify there's a single cell with lots of multinucleation. Again, multinucleation, syncytial trophoblast, and I do have lots of trophoblastic lesions as well, right? Multinucleated syncytial trophoblast with trophoblast and lots of hemorrhage. Lots of RBCs, I'm going to think of it choriocarcinoma. The marker is simple. beta HCG. I can use them as an IHC marker, or I can evaluate in the serology as well. Biochemistry test will tell me, okay, beta HCG is elevated more than what I expect. I'm going to think of a Choriocarcinoma. Fine. Okay. So we had a question on gestational trophoblastic diseases. Let's go to the next one. There's more of a theoretical question. Hope you will write the correct answer. 30 seconds, read through the question and do comment on the answer. Okay, Tanishka started with A. I'm sure it's a very simple one. I'll put this only to discuss the table which is there in Robbins and one finding in the microscopy. It's a simple one, right? I don't want any other clue here. See, we'll go with very, very simple things here. As an 82-year-old person, a very elderly person, having some problem in the right flank, fever for 2 days, and difficulty in urination. Urinalysis shows some bacteria and everything. CT scan finding shows a very large retroperitoneal mass. So it's a very large mass compressing ureter, leading to hydronephrosis of the right kidney. Fine. I'm having a huge mass which is compressing the ureter. Such big mass in an elderly person. What do you think of? Malignancy or benign? With this history, you'll think of malignancy or benign. My first possibility is malignancy, right? I can rule out teratoma, I can rule out liposarcoma. So the other two possibility for me is a malignancy. Liposarcoma, lipoma and teratoma is ruled out. Either it could be a liposarcoma or a rhabdomyosarcoma. Retroperitoneal tumor, unless and proved otherwise, it is going to be a liposarcoma only. Commonality and the age again, 82 years old. Like Satakshi said that I can expect a rhabdomyosarcoma if it is maybe in a child or a younger person. 82-year-old, now the clinical diagnosis for me is liposarcoma, right? That's enough for me to solve the question without the help of image. But I will tell you how to pick up image as well. What is this cell? What cell is this? What cell is that? Can I call it a normal adipocyte? It's a normal fat cell, right? That's going to be a normal adipocyte, right? So normal adipocyte looks like a single large vacuole with a tiny little bit of nucleus in the corner, right? But I am going to shade one more cell in red color, right? I'll zoom a little bit into that. This cell has, can I say this cell has more nuclear content compared to the normal adipocyte? Look at the nucleus of a normal adipocyte. Everything is important for me. There's a tiny nuclei. There's a very small cell, right? Does it have more nucleus? It has more nuclear content, right? There's going to be more nuclear content. I'll comment on that, Swati. Just give me a minute. Second thing, it's lobated, right? More nuclear content, and you have a vacuolated or a lobated cytoplasm. This is called as a lipoblast. Lipoblast means it's a precursor of an adipose tissue, right? So lipoblast is the diagnostic finding given for a liposarcoma. If I see lipoblast in a question, think of a liposarcoma, and a lipoblast in a microscopy looks like this, little bit more nuclear content and lobations, loculations or lobations. When you have that, I'm going to call it a lipoblast. Fine. Okay. Coming to your question, Swati, I'll just erase this so that we can identify whether it is single nucleus or double nucleus. Fine. If you look at this, actually, I'm sure you must have seen about, you must have thought this as the second nucleus, right? This is actually the nucleus of the parenchymal cell. See this nucleus, this nucleus, this nucleus. These are your stromal cells. But this is in sync with the membrane. This is the adipocyte nucleus. If you look at this, my membrane stops here and the nucleus is slightly away from it, right? So that's a nucleus of the stromal cell. So ignore that. Fine. Okay. So that's how a lipoblast looks. If you have a question calling it a lipoblast, say it's a liposarcoma. Fine. Okay, great. So this image, this table has lots and lots of chromosomal abnormalities. I have shaded a few of them. These few of them have come before, or it is clinically important for me to diagnose them, right? So those are the things only I've shared, and you're going to answer them, fine? So Ewing's family of tumors, what is the translocation? These are important for us. Ewing's family of tumors is important for diagnosis also. There are two translocations for Ewing's family of tumors. Translocation, I name one is enough for me. There are actually two of them. Translocation 1122, that's a classical one. The other one is translocation 2122, right? So these are the two classical translocations seen in Ewing's family of tumors, 1122 or a 2122, right? That's important for you. Perfect. 1122 should be more than enough for me. The second one, if you see, I have highlighted myxoid liposarcoma. This came in your NEET, I think the one before this, the last exam, right? Myxoid liposarcoma. What is the translocation seen characteristically? That's seen in both myxoid and round cell type. You will see translocation 1216. The classical translocation seen in myxoid as well as round cell liposarcoma. Third one, I have highlighted the disease. Tell me which tumor will have translocation X18. Again, a classical translocation. Which tumor will have translocation X18? That will be synovial sarcoma, right? Synovial sarcoma will have translocation X18, which is common in exam previously. You have to know that. There's one more thing which came in in regards to synovial sarcoma in exam. Synovial sarcoma on a microscopy, what appearance will it have? Will it have spindle-shaped cells only or something else in addition to spindle-shaped cells? It will have a classical biphasic appearance, right? A classical biphasic appearance that is required for a synovial sarcoma. Do remember about it, fine? Not triphasic. Okay, Satakshi has given us one more lead for one more question. Where do you see triphasic tumors? Synovial will be biphasic. Yeah, perfect. Where will you see triphasic tumors? You will see them in Wilms, right? Triphasic will be Wilms. At least remember these three. Very, very important for either for diagnosis or it just come previously in exam. Because it's a futile exercise for us to remember everything, read everything. You'll definitely forget, fine? Okay, we'll go to the next question. Read this question and tell the diagnosis. 30 seconds again. It's a very simple question which most of you will like. I'll tell Akshit and Swati. Just give me a second. Great. If it is a sarcoidosis, I should have a history like this. Keep this in mind. Just your non-necrotizing granuloma alone will not make it sarcoidosis. I should have a person with arthritis because extra lung manifestations are common in sarcoidosis. Dyspnea, cough, multiple granulomas, both lungs, bilateral hilar lymphadenopathy. Again, that alone is not enough for me. Cutaneous nodules over the trunk. What are these cutaneous nodules called as? We have a term for that. We saw them a couple of days back in an image as well. Erythema nodosum, right? And the most important thing for me is ESR is not important for me. Your AC enzyme, your angiotensin converting enzyme, that is elevated. Serum calcium levels is elevated because the giant cells of a sarcoidosis can produce PTHRP, right? All of them are classical for your sarcoidosis. Once you have all this finding, it's serological diagnosis, microscopy of a granuloma, radiological involvement, and clinical. Only when all these are there, I'm going to think of sarcoidosis. Otherwise, always for every granuloma, I'm going to think of tuberculosis, right? I'll just go up once to tell what are the... Again, as I said, Satakshi, AC enzyme is one of the classical findings seen. It is not like diagnostic point. If I have that along with other findings, then yes, it's useful for me. Otherwise, it's not useful for me, fine? Right? So coming back to your question of Swati and Akshit, what is biphasic and what does triphasic mean? When I call something biphasic, see, when I say face, its epithelium is a face, mesenchyme is a face, so that's called as a face. When I call something as biphasic tumor, I have both epithelial component like a gland or any epithelium and a mesenchymal component like a stroma, right? That's called as a biphasic tumor. So synovial sarcoma will have both stromal lesions, fibroblast like conditions, as well as glandular component, so I call it biphasic. So when I call it triphasic in Wilms, I have three phases. The first two are the same. I'll have epithelial component, I'll have mesenchymal component, those are the first two. The third is very precursor. Whenever I come to precursor, I use term blastemal. So I'll have blastemal component as well. So I'll have epithelial, I'll have mesenchymal, I have blastemal. When I have all these three components, I call it a triphasic or a Wilms. Fine. So these are three phases of Wilms and two phases of a synovial sarcoma. Fine. Great. Okay. So now my diagnosis is simple here. It's sarcoidosis. Fine. So we'll have a quick look about sarcoid granuloma. In the morning, we had a brief discussion about every granuloma, how it happens, right? So tell me what are the unique findings of a sarcoid granuloma? One thing I'm sure everyone here will know is it is non-necrotizing, right? That I'm sure everyone here will know it's non-necrotizing. Swati, all of them are tumor cells in both synovial sarcoma and Wilms. Fine. Anything else apart from non-necrotizing granuloma you know? Yes, it's absolutely non-necrotizing granuloma or a non-caseating granuloma. That's one. Second thing, your sarcoid granulomas will not be will not be coalescing. It will not merge with one another. They are very discrete granulomas. But if you remember tuberculosis, all the granulomas will coalesce together and form a big mass. Okay. I am not able to understand your question, Sakshi. The whole tumor will be biphasic or triphasic, or if you're answering her, yeah, whole tumor will be biphasic or triphasic, respectively in your synovial and Wilms. Fine. So when I say discrete granuloma, I'll have a granuloma like this. If I have a second granuloma here, they don't fuse. But in tuberculosis, they will fuse. Right? If you have a third granuloma here, they don't fuse. Again, the reason for these granuloma not fusing them is surrounding the granuloma, I'll have perigranuloma fibrosis. Fine. I'm going to have perigranuloma fibrosis here. Because of the fibrosis surrounding the granuloma, they don't fuse, right? So I'll have perigranuloma fibrosis. That's also a classical finding seen in sarcoidosis. Right? So we saw a normal granuloma in the we saw normal granuloma in the morning, right? So when you saw a normal granuloma, center you had all the epithelioid cells. What are the cells surrounding them? Some of you also answered them. We saw normal granuloma. The cells surrounding the epithelioid histiocytes, all of them were lymphocytes, right? You had lymphocytes. I won't have lymphocytes here, right? So the perigranuloma lymphocytes will be absent here. Right? In normal granuloma, you'll have lymphocytes. Here the perigranuloma lymphocytes will be absent. That's also classical here. Because I have fibrosis here, I will not have a lymphocytes here, right? So the perigranuloma lymphocytes will be absent. Because of this, it was given a fancy term. We call them a naked granuloma. It will have only epithelioid cells. It will have giant cells. Very little lymphocytes. It will not be completely surrounded by lymphocytes, right? You'll have discrete granuloma, non-necrotizing, surrounded by fibrosis. These four features are very classical for every sarcoid granuloma. Apart from that, we have some name structures. Can any of you name them? There are a few classical name structures in sarcoidosis. Two of them I'm sure you know. You must have seen them as well. One is an asteroid body. You must have seen or heard about Schumann bodies, right? Which is calcification. There's one more thing as well that's called as an Hamasaki-Wiesenberg bodies. These are three different inclusions or your bodies seen in your sarcoid granulomas, right? Asteroid, Schumann, and Hamasaki-Wiesenberg. Again, can any one of you know the differential diagnosis of asteroid body? When I see asteroid body, I cannot write it sarcoidosis. I need this information. Only when it's clinical, radiological, biochemical, and pathological combined, I can call it your sarcoidosis. Otherwise, I cannot, right? Because this is a classical case of an asteroid body. Fine. If you look at this asteroid body, I have different differential diagnoses. Ignore this. You need not remember them. Fine. A tubercular leprosy and berylliosis. Okay, that asteroid body in your sporotrichosis is a bit different from this. In this giant cell, if I see an asteroid-like appearance, I'm going to call it tuberculoid leprosy or a berylliosis with granulomas. Fine, that's possible. Differential diagnosis. Obviously, one more thing is sarcoidosis. Fine. Okay. Now, in asthma, this type of asteroid body, I'll not be able to see it. Okay. Second thing is your Schumann body. This is actually the Schumann body. There's nothing but calcification. It's a calcification seen in the giant cells. Those are called as Schumann body, right? Just to recollect your memory, I have a stain for calcium. What is the stain? We saw it in the morning as well when we discussed about silver stains. What is the stain for calcium? You know that? Von Cosa, right? Von Cosa is stain for calcium. This also will be stained by Von Cosa if at all you require it. Fine. The third one, this might be new for some of you, but I want you to remember this for the only reason this is a very problematic condition when it comes to diagnosis, or alizarin red as well. Fine. So these are called as Hamasaki-Wiesenberg bodies. These are the Hamasaki-Wiesenberg bodies. You can see tiny brown color pigments, tiny round brown color pigments, and they are PAS positive. This is a problem for me. When you have tiny rounded structures like this, if they are PAS positive, will it look like a fungal spore? Does it look like a fungal spore? Very close differential diagnosis and fungal spore. Fungus also unfortunately will cause granulomas. Fungus also can have giant cells. It's a very close differential diagnosis. You should be able to rule out. If you have a problem between differentiating Hamasaki-Wiesenberg body from a fungal spore, you have one more stain for fungus called as GMS. If GMS is positive, it is fungal spore. If GMS is negative, it's your Hamasaki-Wiesenberg body. That's why GMS is a specific stain for fungus compared to PAS, right? So these are few name structures which can be seen in your sarcoidosis. Okay. Apart from the classical granulomas as well. Yeah, looks like a copper bunny body, right? You can have multiple differential diagnoses. Keep that in mind. If it's with sarcoidosis, it's not your copper penny bodies or your fungal lesions. There are something called as chromoblastoma. Few mycos can also have pigmentation. So they are not them. It's your Hamasaki-Wiesenberg body. Fine. Okay, next, read this question carefully and then come to an answer. 30 seconds. Again, I'll go on mute. Answer. Tanishq, residual bodies, the whatever we saw here, the Hamasaki-Wiesenberg bodies, the tiny ones, if they are individual, they are called as residual bodies. Okay, Saraksha has gone with D, B, A. I have different options here. Fine. See, I'll ignore the question. We'll come to the question obviously. We'll just look at the options alone here. Fine. So I have 4 options here. Of these 4 options, tell me the odd one here. Which option is odd one out? I'm not even gone into the question. Which option is odd one out? 16, 18, 31. Can I say all of them will cause malignancy? Yes. HPV6 will cause benign lesion, right? 16, 18, 31, 33, all of them can cause malignancy. 6 and 11 can cause benign lesion, right? So the only odd one out here is 6. Other 3 strains are associated with malignancy. So though most commonly 16 and 18 is more commonly with cancer, but 31 is also linked with malignancy, right? So the odd one out here is option B. So most likely that should be the answer, right? I'm just telling you a few tricks which can help you to come to an answer, that's all. Obviously, I'll go back to the question as well. A 38-year-old person came to the family physician for routine checkup after travel for a year. She recently had a pap smear which was negative for malignancy, right? So I'll tell you, at present, the patient had a pap smear which was negative for any malignancy. NILM stands for negative for intralesional malignancies, fine. Her past medical history, she had a pap smear 2 years back which was reported to have L cell. The subsequent reported to have low-grade intraepithelial neoplasia, right? So 2 years back, the patient was reported as L cell. Okay, patient was reported as L cell. So from L cell, the patient has become negative for malignancy. And the gap here is 2 years. If it was a malignant serotype, you're 16 or 18 or 31, do you think that this transmission will happen? Is it possible for this transfer to happen? Or if it is a malignant phenotype, from L cell, it will become H cell and it might become cancer, right? It's a malignant phenotype, you're 16 or 18 or 31, this is the most probable route. It will not come back to normal. It's coming back to normal means there's only one possibility. Whatever I was dealing with was a benign lesion. L cell is reversible. Low-grade dysplasia is reversible, right? So if it is reversible, here is a classical reversibility. The only possibility is HPV6. I cannot have a malignant serotype coming back to normal like this, so it has to be an HPV6. It's a simple thing. Again, you have to make sure you are trying to relate the histories. If you are able to try to relate the histories, you can come to a conclusion easily, fine? Okay. I'm sure you'll know that the HPV 16-18 and your HPV 6 and 11 will cause benign, malignant and benign respectively. And I'm sure you also must have learned about the proteins, your E6 and E7 proteins, which cause malignancy. The only difference is both of these guys will have E6 and E7. Both malignants as well as benign will have E6 and E7. But malignancy, the virus gets integrated into the DNA. It integrated into human DNA. That's a problem. When I say integrated to human DNA, am I right in saying that whenever the cell divides, HPV DNA also will divide and it will cause E6 and E7? Yes. And here they are not integrated, right? They are just like an episomal form. As an episomal form, it's like a plasmid seen outside, right? Since it's integrated DNA, the amount of E6, E7 produced is going to be humongous amount, and definitely it can cause genetic change, it can cause cancer. That's the only difference between HPV 16, 18 or any malignant phenotype compared to your benign phenotypes. Fine. Okay. Next question. Now again, it's a simple one. 30 seconds should be more than enough. Answer? Comment on the answer. Anyone? It's a simple one, right? Okay, at least tell me the diagnosis. It's a very, very classical case. 75-year-old person. That's a simple one. Great. It's Alzheimer's and most likely option D, right? We'll go through the case. We'll see what's the diagnosis. Then we'll come to the answer. It's a 75-year-old person, a repeated history of forgetfulness, and it has increased a lot. And searching class, everything is there. Recently lost the driver license, everything is there. So it's going to be dementia, forgetfulness in an 75-year-old person. I'm going to think of an Alzheimer's, right? Some of you answered B. It's fine. Alpha-synuclein defect will cause Alzheimer's or Parkinson's. This will cause Parkinson's, right? So alpha-synuclein defect will cause Parkinson's and not Alzheimer's. So this is a case of Alzheimer's. Alzheimer's, the simple thing is, it's an A-beta amyloid deposit. It's an A-beta deposit, so it's going to be an abnormal cleavage of an amyloid precursor protein. APP is your amyloid precursor protein. This abnormal cleavage of an amyloid precursor protein, APP, will result in an A-beta amyloid which gets deposited. And when amyloid gets deposited, over the period of time, it will destroy the neurons. So I'm going to have your Alzheimer's disease, right? So just have a quick look about amyloid precursor protein and see about the pathogenesis of Alzheimer's disease. CNS Alzheimer's is purely a clinical diagnosis. MRI might help at some point of time, right? But pathogenesis generally is not much concentrated for an undergraduate level for the simple reason that I don't have any good answer for it yet. If I'm able to reverse it, pathogenesis becomes very, very important for me. So if you want to learn for any disease for that matter, if you want to learn about a disease in depth, I want you to remember the pathogenesis, because almost every changes comes from the pathogenesis, more importantly physiology, fine? So look at this. This is your amyloid precursor protein. You can see here, this entire thing is an amyloid precursor protein. It has a carboxy end, and like any other protein has two ends, the amino and the carboxy end, fine? So what happens in a non-amyloidogenic fragment? In all of us, I'll come to Rakshit. In all of us, what happens is, in you and me, everyone has this amyloid precursor protein, right? I'm going to have an beta secretase, alpha secretase, and gamma secretase activity, right? So when it acts in for you and me, I'll have an alpha secretase acting and I'll have a gamma secretase acting, and there'll be a very little amount of beta secretase activation, fine? So beta secretase will not act for all of us. So which means it's going to destroy the protein and this becomes soluble. Once it becomes soluble, any protein is very, very simple for me to remove, and these also will be removed. So I won't have any stored protein. So it's a normal protein, like any other protein. It's going to be cleaved and like an ubiquitin proteasome pathway, and it will be lysed easily. That's your non-amyloidogenic form. This happens in normal. Let's see what's going to happen in Alzheimer's patient. See, I'll go to the top part again to keep in the normal, the left side, and it happens in amyloidogenic part. In an amyloidogenic part, what's going to happen is a gamma secretase happens, but a beta secretase happens. My alpha doesn't happen here, right? So when alpha doesn't happen and beta secretase defect happens, this will be soluble. This intermediate red portion becomes an A beta peptide. That's your amyloidogenic peptide. So the secretase defect is a problem, right? So there are few mutations which are predisposed for Alzheimer's disease, which is going to be a defect in your alpha secretase. You can see here, in a normal alpha secretase is here. Here there's no alpha secretase. So absence of alpha secretase or an excess of beta secretase can cause A beta protein. So A beta protein is a problem for me. Again, it's not a problem if it's one protein. It's a problem when it becomes oligomers and polymers. If it becomes too many for a period of years, that's why Alzheimer's age is most important for me. Over the period of years, when this keeps on accumulating, it's going to cause many, many problems, right? So one of them is your question, Akshit, here, it is here. The A beta oligomers can cause many, many other effects. It can cause cell death. It can cause synaptic dysfunction. It's a protein. It goes and gets deposited in synapse. The transmission will be abnormal. Again, it's an amyloid protein. It will deposit surrounding a blood vessel, reduce blood supply, cause cell death. It can cause kinase activation as well. That kinase causes my tau protein. The tau protein also causes neuronal disassembly, right? So tau protein is like an outcome of A beta amyloid. A beta amyloid is totally different. Tau phosphorylation is totally different, right? And the tau, once it's phosphorylated, it also gets aggregated and causes your plaques and your tangles. This finally destroys. This is the lesion seen in microscopy. Fine? Clear? Akshit, I hope you understood the difference between APP and your tau, right? Great. So this is what happens in amyloidosis, right? So I'm sure you must have read about few genes. There are few genes which can predispose to amyloidosis. One is called as PSN1 and 2, presenilin 1 and 2. Fine, these are one gene. The second thing is APP itself, amyloid precursor protein itself, right? So can any one of you name at least one syndrome which has increase in risk of amyloidosis, which also has increase in risk of leukemia, which can cause intellectual disability? It's one of the live trisomies. Which syndrome is that? Down's, right? Down's definitely has an increase in risk of amyloidosis. I'm sure you know that, right? So this amyloid precursor protein is in chromosome 21. The location of amyloid precursor protein is chromosome 21. So in a Down syndrome patient, I'm having 3 chromosome 21s. When I have 3 chromosome 21, the amount or the load of amyloid precursor protein is more than any one of us. So the amount of this A beta aggregate will be more than any one of us. That's why they can have Alzheimer's even early in life, right? So Alzheimer's, most of us might have Alzheimer's, fine, right? Yeah, too many hints, that's fine. If you remember the hints in a real life, in your exam, you'll definitely not forget it, that's all, fine. All of us, if I live for 90, 100 years old, this A beta oligomer will get deposited. It's a senile change. But these people with a genetic predisposition will have an early onset Alzheimer's. All of us, if I'm going to live for long, I will eventually develop an Alzheimer, but at 80 or 90 or 100, my body will be able to take care of it, right? But when I have a mutation, which is like a secretase defect or an overexpression of a secretase, that's your presenilin 1 and 2, or an APP excess, I'm going to have an early onset Alzheimer's, fine? So these are few things, the genetic component and the pathogenesis of Alzheimer's, fine? And just one more question regarding amyloid. What is the first, in a biopsy or in any location, which is the first structure amyloid gets deposited? Like it gets deposited in epithelium or mesenchyme, which structure? Amyloid always gets deposited around. This is all over the body. Amyloid all over the body, whatever may be the amyloid, the preferential deposit surrounding blood vessels. It gets deposited surrounding the blood vessels only. That's why even in Alzheimer's, in your medicine or in your radiology, have you heard of something called as cerebral amyloid angiopathy? You must have heard about this for sure. Cerebral amyloid angiopathy, because again, even in Alzheimer's, it goes and gets deposited in the blood vessels. Yes, extracellular in the blood vessels, right? So that's one of the findings seen in cerebral amyloidosis involving Alzheimer's as well. Fine. Okay. So that's for today. So any doubts? If you have any doubts, let me know. So we have discussed today about few things. The first thing was we took time to discuss about nephritic nephrotic syndrome. I hope you are able to extrapolate and visualize your viral loop lesion and the stages of SLE. Then we saw about molar pregnancy. We saw about P57 and its importance. We saw about the different classification of gestational trophoblastic disease and choriocarcinoma. And one tiny thing about lipoblast and few mutations required for us. And also we saw about sarcoidosis, the appearance of a sarcoid granuloma, the 4 different types, the 4 important things: non-necrotizing, discrete, perigranuloma fibrosis, naked granuloma, asteroid body, Schumann bodies, and your residual or your Hamasaki-Wiesenberg body. And one thing about your HPV virus, fine? Sure, Advaita, tell me. Okay, if you have no other doubts, you can call it a day. Advaita, tell me how I can help you in admission. You can comment. I would prefer DY Patil. So again, whatever information I'm giving from other colleges, apart from my parent college, are based on my colleagues or students who are sitting there, right? So if you can get a chance to visit both the hospitals, it will be the best decision. But personally, I would prefer DY Patil. Okay. Mumbai is better than Pune, but I think Pune is also not a bad institute, definitely good. Mumbai, Pune, and then Krishna. Fine. Pixie dust, I don't have much of an idea about indoor MGMMC. Give me some time. I'll ask if any one of the students or friends are there. If I can give information regarding that, I can help you in future. Just text me once. I'll try to gather resources regarding MGMC indoor. Okay. Fine. Thank you guys. See you soon. Bye bye.